Hey everyone, and welcome! Today, we're jumping into a topic that shows up all the time in clinical practice: blood in the urine. Now, this can be anything from a totally benign issue to a full-blown emergency. The trick is knowing how to think like a detective and figure out what's going on. So, let's dive in.
Okay, just the usual but super important reminder before we start. This is all for educational purposes. It's not a substitute for professional medical advice. If you have any health concerns, please go see a qualified professional.
All right, picture this. A patient comes to you and says, "I think there's blood in my pee." Immediately, your brain probably floods with a dozen different possibilities. But what if I told you there's one single question you can ask right at the start that cuts through all that noise and points you in the right direction? We're going to get to that right now.
So, here's our game plan. First, we're going to build a really simple, powerful framework for thinking about this whole problem. Then, we'll explore the two main roads you can go down, the painful one and the painless one. And we'll finish up with some must-know facts for your exams, a quick quiz, and a final summary to tie it all together.
Okay, let's get that mental framework built. Honestly, the key to not getting overwhelmed is having a solid system. And it all hinges on the answer to that one critical question we just talked about.
First things first, let's get the language right. The medical term is hematuria. Pretty simple. It just means blood in the urine. Now, this can be visible or macroscopic, which is when the patient can actually see it. The urine might be pink or red, or it can be non-visible or microscopic, where the urine looks totally normal, but we find tiny amounts of blood using a dipstick test.
And here it is. This is the master key, the most important fork in the road. You have to ask, does it hurt when you pee? Because if the answer is yes, your brain should immediately think of things that irritate and inflame, like infections or kidney stones. But if the answer is no, well, that's when a different set of alarm bells should go off. While it could be a few other things, the one we absolutely cannot afford to miss is cancer.
So let's head down that first path together. We're investigating painful hematuria, where something is clearly causing active irritation. All right, first up, the super common urinary tract infection, or UTI. The easiest way to think about a simple bladder infection, what we call cystitis, is to imagine some bacteria have snuck into the bladder. They're like little graffiti artists, setting up shop and irritating the bladder's sensitive inner lining. That irritation is what causes all the inflammation and that classic burning pain. Now for the science behind it. Most of these infections are caused by bacteria traveling up from the gut, and the main culprit by a long shot is E. coli. This bacterial invasion triggers an inflammatory response in the bladder lining, and that gives you those classic symptoms: dysuria, which is just the medical term for painful urination, plus frequency and urgency. Now, if those bacteria manage to travel all the way up to the kidneys, it becomes a much bigger deal called pyelonephritis, which can make you systemically sick with a fever and pain in your side.
The other huge cause of painful hematuria is a kidney stone. And the analogy here is just perfect. Imagine trying to force a tiny, sharp piece of gravel through a garden hose. That hose is your ureter, and it's going to spasm and squeeze like crazy to try and push that stone out, causing these intense waves of scraping pain. So how do these little things even form? Well, it's basically a three-step recipe. First, your urine becomes supersaturated. That's a fancy way of saying it has too many minerals, like calcium, dissolved in it. Second, those minerals start to clump together and form tiny seed crystals. That step is called nucleation. Finally, more crystals stick to those seeds and they grow and grow until you have a solid stone, ready to cause trouble.
Okay, checkpoint time. This is a really, really important safety point. We know a kidney stone hurts a lot. But what two things, when they happen at the same time, turn this from a painful problem into a true sirens blaring emergency? The answer is an obstruction plus an infection. Think about it. If a stone is blocking the flow of urine and you have bacteria trapped behind that blockage, you've basically created a high-pressure, infected abscess inside the kidney. This can lead to life-threatening sepsis really, really fast. It's a combination that needs urgent, immediate intervention.
All right, let's completely switch gears and head down the other pathway. This is the one where we have to be extra sharp, because the fact that there's no pain can actually be misleading.
You need to burn this phrase into your brain. Painless, visible hematuria is bladder cancer until proven otherwise. Now, that does not mean every case is cancer. Of course not. What it means is that our level of suspicion has to be sky high. It's a massive red flag that demands a full and thorough investigation to rule out something serious. We just can't ignore it.
So what's going on here? Well, just look at the single biggest risk factor for bladder cancer: smoking. It's not even close. Here's why. The carcinogens from tobacco smoke get absorbed into your bloodstream. Your kidneys then do their job and filter those nasty chemicals out into your urine. But then that concentrated, chemical-filled urine just sits in your bladder for hours, constantly bathing the delicate lining. That long-term exposure is what can lead to cancer.
Now, when we talk about bladder cancer, the single most important question we have to answer is whether it's non-muscle invasive or muscle invasive. Basically, is the tumor just on the superficial surface lining, or has it dug its roots deep into the main muscle wall of the bladder? Knowing the answer to that one question changes everything: the prognosis, the risk of it spreading, and the entire treatment approach.
Okay, time to switch into exam prep mode. This is a quick-fire round of the absolute must-know, high-yield facts that you need to have locked in.
Let's talk about when to make that urgent referral. In the UK, the NICE guidelines are super clear. Anyone who is 45 or older with visible blood in their urine that you can't explain gets an urgent referral, period. For non-visible blood, the bar is a bit higher. You have to be 60 or older and have other symptoms like pain or a high white blood cell count. The logic is simple. Blood you can see is just a much bigger red flag.
And here's a classic prescribing trap that you'll definitely see on exams. The antibiotic Nitrofurantoin is great for a simple bladder infection, a cystitis. Why? Because it gets highly concentrated in the urine, right where the bugs are. But that's also its biggest weakness. It doesn't actually get into the kidney tissue very well, which makes it the wrong choice for a kidney infection, a pyelonephritis.
Okay, we've walked through the framework and the main culprits. Now it's your turn. Let's see if you can apply what you've learned to a quick clinical case.
Okay, listen to this scenario. You have a 68-year-old man, he's been a smoker his whole life, and he comes in after having 2 separate episodes of seeing blood in his urine with no pain at all. So what alarm bells are ringing, and what's the single most important next step? The answer, without a doubt, is an urgent cancer pathway referral. He's ticking all the boxes. He's over 45, it's visible hematuria, and he has a huge risk factor.
All right, we have covered a ton of information. Let's take a second to just boil it all down to the key need-to-know messages that you can take away from this.
So let's recap. If there's one thing you take away, it's the framework. Always start by asking, is it painful or painless? If it's painful, you're thinking infection, and you're thinking stones. If it's painless, especially if it's visible in an older person, your number one concern has to be malignancy. And remember our 2 absolute emergencies: an infected, blocked kidney, and that new case of painless visible blood. Oh, and one last clinical pearl. It's really common to want to blame blood thinners, but you can't. The rule is you must investigate anyway, just to make sure you're not missing an underlying cause. Thanks so much for joining me.